forward, we have Dr. Radhika Manohar, neurologist and clinical neurophysiologist at Narayana Institute of Neurology, Bangalore. Thank you, Dr. Radhika, for accepting the invitation. And we are looking forward to your participation. She will be taking up about 15 to 20 cases, and the program will be a semi-interactive program. The audience will get an opportunity to raise questions and she'll be able to answer. But for each case, I don't think we'll be able to interact with each other. So because of the online program, we have to put up with this. So Dr. Radhika has worked in UK in various centers in the capacity of clinical neurophysiologist. She has experience in intraoperative recordings of nerve conductions and EEG. And after that, she moved on to work in Narayana Institute, and she has been working for more than 5 years, I think, in Narayana. And she has a vast experience in this field, and she is the right person to take it forward. Dr. Radhika, please take over and continue with the proceeding.
Thank you, Dr. Sharma, for your kind words. So yeah, I'm actually a clinical neurophysiologist by trade. That's my area of specialism. And this is going to be about nerve conduction studies and electromyography. But what we have done is split it into two halves so that it's not too heavy in just one presentation. So I'll start off with sharing my slides. Okay, I think everybody can see this, isn't it?
Yes.
Yeah, shall we go ahead then? Right. So what are we going to do today? I'm presuming that all of you have joined today, you have a basic knowledge of nerve conduction studies. You would have reported nerve conduction studies over the years. And even for the residents, you would have had a look at them. You would have put needles in muscles. So it's not going to be basic in the form of, what is a nerve conduction study, but it will be fairly basic as regards concepts, because that's the thing. The most important thing here is the concepts. So we'll go through about the characteristics of nerve conduction responses. So quickly, we'll just recap what a SNAP is, what a CMAP is. So SNAP is sensory nerve action potential. CMAP is compound muscle action potential. Then we'll talk about how we approach these nerve conduction studies. So we first start with localization. Is it preganglionic versus postganglionic? Patterns of various patterns of nerve damage. Is it axonal or demyelinating, or could be a mixed picture? And then the approach to a nerve conduction study. When somebody hands you a set of data, how do you go through it? How do you make sense of it? Quickly tell you what are the parts of an electrodiagnostic report that we normally put in. But the main part of the presentation is going to be cases. So we'll go through some focal peripheral nerve lesions. We'll go through plexus lesions, how to approach plexus cases, and peripheral polyneuropathies. But why do we bother with nerve conduction studies? We have a history and we have a clinical exam. Then why do the nerve conduction study? The point is, our history and our clinical exam only takes us thus far and no further. So we get to a patient, they tell us they've got some sensory symptoms in the hands, some jum, some weakness, and we are able to say, okay, that could be a carpal tunnel syndrome, but that could also be a lower trunk of the brachial plexus lesion. It could be a radiculopathy, but that's all we can go. Anything further, we need help from nerve conduction studies. So it is very much an extension of the clinical exam. It is so much an extension of the clinical exam that if you get data on your nerve conduction studies, which when you go back and check with the patient, still does not have any clinical correlates, then I would rather ignore the electrophysiological data, as long as there is no clinical correlate, obviously, and go with the clinical pictures. It is very much a part of the clinical exam. You shouldn't treat any patient just based on the nerve conduction data. It also helps us to characterize the lesion. So obviously we know now whether the nerves are affected, the patient is given a symptoms, is there evidence of organic damage in the lower motor neuron? Then we try and characterize it, what type is it, what's the distribution, because all that will help with the etiology. What is causing this, what is the reason for the patient's symptoms? Then eventually especially when we do the electromyography, sometimes with the motor responses also, but also with electromyography, we can then talk about the severity of the lesion. How bad is the lesion? Is it severely axonal lesion, or is it just a neuropraxia with focal demyelination? And finally, we can prognosticate. Prognostication also will depend on the motor responses as well as our electromyography. Right. So the CMAP, compound muscle action potential, sensory nerve action potential. That's your sensory response. response. The first one is your motor response. And lots of values to it, isn't it? But the most important values you need to remember are the latencies. This is the distal motor latency, and this is the amplitude. And then there is a conduction velocity, which we'll quickly talk about in the next slide. Then the sensory nerve action potential, you have your amplitude again, and your onset and your peak latency. Latency is the time it takes for the response to come up following stimulation. So your stimulus artifact is here, and then you stimulate at that point. It takes a few milliseconds, and then you have your response coming up. So all these are important. As you know, the latency and the conduction velocity are directly related to demyelination, while the amplitude usually means axonal loss. Any any involvement of the amplitude usually means damage to the axons. This is how you calculate the conduction velocity. So that's the distance. Conduction velocity is speed. Speed is equal to distance divided by time. And this is the distance between the 2 points of stimulation along a motor nerve. So you need 2 points because you are actually stimulating the nerve and you are recording from a muscle. So there is conduction along the neuromuscular junction as well as the muscle, both of which are very weak areas of conduction. So they actually slow down the rate of conduction and you don't get the actual conduction velocity in the motor nerve. So that's why you stimulate at 2 points and then you can almost subtract this part. So you get your pure motor conduction velocity along this length of the nerve. And that's why you stimulate a motor nerve at 2 points to get your conduction velocity. So this part is a localization, and this is really one of the most important things when we approach a nerve conduction study. So you know that the sensory nerve action potential looks at the sensory responses, this part of the peripheral nervous system. That means the sensory responses from the skin here all the way as an afferent towards the dorsal root ganglion. When we keep saying ganglionic, we mean the dorsal root ganglion. So this bit is postganglionic. Distal to the dorsal root ganglion is postganglionic. So the sensory nerve action potential will be affected in postganglionic lesions as long as the nerve that you are testing has a sensory part, and also the sensory part can be easily tested using your nerve conduction study. So suppose you have a nerve like the axillary nerve that you know that it has a postganglionic part, it has sensory abnormality, it has sensory branches, but we can't reliably test it on nerve conduction studies. And hence, it's very difficult in such nerves to say whether, whenever you have a lesion in that area, whether to say it's postganglionic or preganglionic. But when you have median nerves, radial nerves, ulnar nerves, very easy to test. So there you can easily use this method to see whether the lesion is postganglionic or preganglionic. So postganglionic lesion means sensory nerve action potential is affected, and it usually almost always, to peripheral nerve and the plexus, either brachial or lumbosacral. Now, preganglionic goes from all the way from dorsal root ganglion to the sensory nerve root, motor neuron as well. Now, we use the term preganglionic very loosely. Sometimes we say preganglionic to also mean the motor axons, including the neuromuscular junction and the muscle. But strictly speaking, what we're looking at here is the ventral root and the motor neuron. Okay, in that the sensory nerve action potential will be preserved because you are testing the sensory nerve action potential up to the dorsal root ganglion, and your lesion is beyond, is proximal to the dorsal root ganglion, and hence it is a preganglionic lesion. So again, just reiterating the points so that you really understand what this is about. So this is your dorsal root ganglion. This is where your stimulus is, and this is where your lesion. This is a normal study. Here you have a normal sensory nerve action potential and normal compound muscle action potential. But here you have a proximal lesion, which is a preganglionic lesion, either at the level of the root or the level of the anterior horn cell. And the lesion is proximal to the dorsal root ganglion, in which case your sensory nerve action potential will be normal because your sensory nerve action potential or your SNAP is tested at this point. And so you get a nice normal SNAP, but your CMAP is reduced. Your CMAP is reduced because it's preganglionic. There are other areas also where the CMAP is reduced, but we'll talk about that later in our last few slides. So in the same way, the postganglionic lesion means distal to the dorsal root ganglion. As lesion is here, the sensory nerve action potential is affected, and usually the lesion will be at the level of a peripheral nerve or one of the plexuses, in which case you get a sensory nerve action potential which is affected, as well as a CMAP which is also affected. So as you can see, CMAP will get affected in both preganglionic and postganglionic, but the level of affection, the level of involvement in the CMAP will also depend on the etiology, the cause. So for example, in acute radiculopathies or acute root lesions, the CMAPs will not be affected immediately. But chronic radiculopathies, the CMAP can get affected. So that's the sort of thing. So in acute radiculopathy, you rely on the EMG to localize, while your SNAP and CMAP can be now. Okay. So we talk about localization. There is also distribution of abnormalities, which we'll talk about later. But the next one that we look at is characterization of the abnormality. So the characterization of a nerve damage is going to be either axonal or demyelinating. So it's very easy. When nerves are affected, they only respond in one of two ways. The damage is only in one of two ways, axonal or demyelinating. So it could be a focal axonal, like a single nerve with axonal damage, or it could be a generalized axonal, like a generalized axonal neuropathy, or it could be a focal demyelinating, like carpal tunnel syndrome under neuropathy, for example, or it could be a generalized demyelinating, like CIDP, for example. So axonal is much more common, as you know. Reduced amplitude is what you see in your SNAPs and CMAPs. So if it's a postganglionic axonal, reduced amplitude in the SNAP as well as CMAP. If it's a preganglionic axonal due to root avulsion or a motor neuron disease, then your CMAPs will be affected while your SNAPs will be spared. And the CMAPs will be affected by reduction in the amplitude of the CMAP. And conduction velocities and latencies are quite well preserved in axonal lesions. And the reason they might be affected is if the axonal loss is so severe that there is loss of the fast conducting fibers. Sorry, am I breaking up?
Yes, some noise is there, madam. Background.
Somebody is unmuted himself.
Now it is.
Yeah.
Now it's better?
Please go ahead.
Okay, I'll carry on then. Okay, sorry. So what I was saying is that if there is loss of fast conducting fibers, even in an axonal neuropathy, you can have a slight reduction in conduction velocity and a slight increase in latency. These are usually seen in demyelinating neuropathies, but even in axonal neuropathies, this can happen because of affection or because of involvement of the fast conducting fibers, where the conduction velocity and the latencies in a nerve are actually not determined by the average conduction velocity and latencies of every fiber in the nerve. It depends on the fastest conducting fibers. So if the fastest conducting fibers are affected as part of the axonal process, then you can have a mild reduction in the velocities and a mild increase in the latency. But these are relatively mild, and we have criteria which help us divide between like a primary demyelinating versus a secondary demyelination. Yes, so that is the European Federation of Neurological Societies EFNS criteria, which I'll show you in a later slide. Now, demyelinating pattern is much less common, as you know. You will see generalized peripheral neuropathies much more often, don't you, rather than seeing CIDP. CIDP is a relatively rare condition, even in a tertiary neuromuscular clinic. It's still relatively rare. So it's much less common, and it usually presents with a reduced conduction velocity, increased distal motor latencies, and then it can cause secondary axonal loss, as you can see. It also causes conduction block, which we'll talk about in a minute. So you can see distal latencies here. This is increased by, if it's a median, it's about 4.4 milliseconds, and now it's 6.8. And the conduction velocity should be 49 meters per second or above in the upper limbs. Now, it's, as you can see, it's reduced, and it's more than half reduced. So that's what a demyelinating neuropathy looks like. So quickly to go through electrophysiological features of demyelination, as you mentioned, we've mentioned already. So in the sensory nerve, in the SNAPs, what you see is the peak latency and onset latencies are delayed, and the conduction velocity can be reduced. Amplitudes can be reduced, but that'll be a secondary reduction, secondary axonal loss, with the primary demyelinating neuropathy with secondary axonal loss. Now, all our demyelination, all our diagnosis of demyelination, electrophysiological diagnosis of demyelination is based on motor conduction studies. Sensory conduction studies don't have the same weightage. The reason is because the sensory conduction studies, the sensory responses that we record are tiny responses. They are in the measure of microvolts, while the motor responses are millivolts. So they're much easier to see, much easier to elicit, and much easier to see on the screen. And you can place your cursors, these things called cursors. You can place the cursors very clearly there, while if you see the sensory response, the upshot, the uptake is not so clear. So you could move your cursors a little bit. And when you move your cursors, you can get different velocities. So it may not be the right velocity. So that's why when we diagnose a demyelinating neuropathy in non-nerve conduction studies, we diagnose it based on motor responses, based on CMAPs. So we also see, along with our latency prolongation, along with conduction velocity slowing, along with secondary axonal loss, we also see something called conduction block. So this is stimulation of the median nerve, recording from the abductor pollicis brevis. Distal stimulation here, you get a nice distal response, CMAP here, nice normal. You stimulate more proximally, you get another response. You can see there is no drop, there is no change in the amplitude between the two responses, and that's a normal response. But when you look at somebody with a demyelinating neuropathy, you have this phenomenon called conduction block. Because of segmental demyelination. Demyelination is not uniform, as you see in inherited neuropathy. It's patchy or it's segmental. So distal stimulation, you get a nice, decent response. It may be reduced if there is secondary axonal loss. Otherwise, it will look normal with a nice normal amplitude. But when you stimulate more proximally at the cubital fossa, in this example of the median nerve, you can see that the response is reduced. The size of the response has reduced, and you can see the latency has increased here. So there may not be distal latency prolongation. All you might get is conduction block. Along with it, you'll also have conduction losses slowing. But a few things you must remember before diagnosing conduction block is the distal amplitude that you're measuring, the amplitude that you're measuring, the CMAP that you're measuring from the APB here should be at least of 1 millivolt size, or it should not be more than, it should be more than 20% of the lower limit of normal. Because if you have a very small response, then again, you won't know where to place the cursor. And if you move the cursor, remember, you get an erroneous reading. Okay, so also duration increase should be less than 30%, because if the duration is increased, then it is something called temporal dispersion, which is what you see here. So here it looks like a conduction block, but it could be because the area under the nerve is increased, is delayed, duration is increased by more than 20%. So the actual reduction amplitude is not a direct conduction block. It's more of a dispersion, temporal dispersion, and that's called temporal dispersion. The previous slide is conduction block. Both these carry the same weightage. So normative data, you probably know it already. I've just put up a slide just in case, but it's available in Shapiro in any books. Important thing is when you have your own lab, as far as possible, see if you can collate your own normative data, because that's really the best way to take this forward. It's very difficult to understand, or at least speak to the labs in your area, near your area, and see if you can use the same kind of data. So Indian labs, all of them, they can use the same kind of data because it's different. Caucasian data will be slightly different to Afro-Caribbean data, will be different to Asian data kind of thing. So, but you must do some sort of a collaborative effort and try and get something together. So how do we approach a nerve conduction study? Know your patient. So like I said, extension of the clinical exam, not more important than the clinical exam. Nerve conduction study is not more important than the clinical exam. Clinical exam is really the most important thing, but it's a focused clinical exam. You're not going to sit there and take a family history unless it's relevant, unless you're looking at inherited neuropathy or a myopathy or a pediatric case. Then yes, you might go into all those details, but otherwise you're looking for a focused clinical exam and a very focused history. And also then make sure, once you've taken your history and exam, you need to know that you're testing the right nerves. Have you selected the right nerves? The other thing is your technician would have done some tests and sent, given you the answers, isn't it? The data. So you must then go back to the patient, check if the correct nerves were tested. The next thing is finally you're happy with you're happy that this is what that you're looking at, and you need to evaluate the data. When you evaluate the data, I prefer looking at the sensory responses first, and then the motor responses, because in my mind, always we start with localization. So we start with pre versus post ganglion. So if you look at the sensory responses first, you know then immediately, sensory responses are normal, but the same nerve is showing a reduced motor response, means then you know in your mind that's preganglionic. So that makes it easier. But remember, all the technicians and all of us, people who do the nerve conduction studies also, we do the motors first and then the sensories, because the motors are robust responses. They're easier to get, and there is less technical issues with motor responses. Well, snaps are more difficult to get. So there's always that thing where we do the CMAPs first and then the snaps, but ideally interpret it the other way around. Okay, so once you've looked at your data and you've seen that the snap and CMAPs are abnormal, the next thing you want to know is you want to localize. Is this preganglionic versus postganglionic? Next thing is it focal versus generalized? And when you say generalized, immediately in your mind, you must also look for clues of whether it's a symmetrical generalized or whether it's an asymmetrical generalized. Okay, because all that will help you with etiology. And then finally, and obviously very importantly, characterization of the neuropathy or characterization of the lesion that you have. Mostly it'll be a neuropathy where you'll be able to say if it's axonal versus demyelinating, or even if it is an abnormality in the response itself, you can see if it's an axonal abnormality or if it's a demyelinating abnormality. For example, a radiculopathy will cause an axonal abnormality. It might have caused a demyelinating abnormality very proximally at the root level, which we cannot test for, but we are only seeing the result of it in your motor responses or in your EMG. Okay, so that's the way we really look at it. So localization first, distribution second, which is focal versus generalized, symmetrical versus asymmetrical, and then characterization finally, which is axonal versus demyelinating. So EMG is, we'll talk about it later during the second part of it. But after looking at the nerve conduction study data, you need to go and think about the EMG, how you're going to plan the EMG. You have a better idea now. You have a differential diagnosis, which you want to see whether that confirms it, or sometimes you don't have a differential diagnosis. After nerve conduction studies, you're still confused, in which case you still have the EMG will help you in continuing the diagnostic process. And when you do your EMG, select the appropriate methods, muscles. And when you start doing the EMG, you will then look for whether the primary process is neurogenic or myopathic. These are the things that we do in EMG, which we'll talk about later again. Don't worry. So this is what we normally do with a electrodiagnostic report. So this is, we have a summary of tests. So we like to just say sensory responses is what it showed. So people don't have to pour through the data. Only a neurophysiologist or a neuromuscular specialist will then go through the data itself. Motor studies is what we showed. If we did any other specialized nerve conduction studies is what we showed. Electromyography. What do we see? We saw reduced recruitment and there was no spontaneous activity. Nothing else was mentioned. Very important to mention the duration of onset, especially when you're thinking about peripheral nerve or plexus lesions. So peripheral nerve injuries or any peripheral nerve symptoms or plexus lesions, you must talk about onset, duration of the study, onset of symptoms, because as we know, it takes about 5 to 7 days for the motor response to be affected first, at least 7 days for the sensory response to be affected, and then up to, I mean, earliest is 10 days, but 2 to 3 weeks for the EMG abnormalities to come. So duration is really important. Duration of symptom onset is really important. And then we just put a little opinion here. And then if we were specifically thinking of something else, we tell the referrer that there was no evidence for that particular thing. Okay, so let's start with the cases itself. Okay. Sorry, I'm just trying to, I can't actually see the one on top. Okay, 62. Sorry, Shailendra, can you help me with this? I can't see because of the panel on top.
Okay, madam.
I can't just see. I can't see my first line actually. But that's okay. So it says here, 62-year-old gentleman who presented with suspected carpal tunnel syndrome. Okay, so that's your patient. So you know your patient. So that's your nerve conduct. That's your clinical information. Next thing, you have your data. So you have sensory nerve conduction studies, motor nerve conduction studies. As I said, I like to look at SNAPs first and then CMAPs because I wanted my mind to characterize whether this is, to localize whether it's pre or post ganglionic. So what are the electrophysiological abnormalities seen here? So this is your left median sensory response. You're going to look at your onset latency, peak latency, amplitude, and nerve conduction velocity. So you can see nerve conduction velocity is slightly reduced compared to the ulna. And the right median snap conduction velocity is also reduced compared to the ulna, and the amplitudes are within normal limits. Okay. So those are the abnormalities on the nerve conduction studies. Now, immediately go to the motor conduction studies. So based on the nerve conduction studies, you would be right in thinking that there is focal demyelination across the carpal tunnel. So there is evidence of median neuropathy at the wrist. I think that's fair to say. It's relatively mild. So then you look at your motor conduction studies. So if you see the left median motor response looks normal, amplitude, latency, conduction velocity is normal, 4.2 to 4.4 milliseconds, depending on which lab you work in. But if you look at the right median motor response, you can see that the latency is actually delayed here. While the amplitude is reduced, there's a slight reduction in conduction velocity. Now, you could say that this is carpal tunnel syndrome, and that's it. There is nothing here other than carpal tunnel syndrome. So you have a left mild carpal tunnel syndrome because the motor studies are not at all involved. Latencies are normal. And you could say there's a right moderate carpal tunnel syndrome because the sensories are slightly slow and the motor shows a delay in latency. But the issue we have here is the amplitude. the amplitude reduction here is out of proportion to what you would expect with just this latency prolongation and with a preserved, almost a completely preserved median snap. So what that tells us, here the question, are there any further nerve conduction studies or EMG tests that you would like to do? What that tells us immediately is that we should be thinking of a proximal lesion here. So either we should be thinking of a plexus lesion or we should be thinking of a root lesion. Now, root lesion is probably more likely because the rest of the sensory responses are normal. Rest of the sensory responses which could tell us about a plexus lesion, which is a postganglionic lesion, they are normal. Hence, a root lesion could be more likely here. And that you can only really exclude by doing an electrobiography test or an EMG test. Okay. So this is what a typical nerve conduction study looks like, just so that you know. So you have the conduction velocity slowing and the latency prolongation here, and amplitudes are slightly reduced at the right median snap, while the conduction velocity is also more reduced, more delayed, more reduced on the same side, as you can see there. And you can also see the comparison studies lower down here between digit 4 median and ulnar comparison studies, and you can see that it's delayed in comparison to the ulnar snap from digit 4. So that confirms some sort of slowing in the focal slowing in the median nerve. So it's postganglionic, it is focal, and it's bilateral. And looking at the motor studies, you can see that there's a delay in the latencies bilaterally, and the amplitudes, as you can see, are much better preserved than our previous study here. So 2.8 for 5.1 milliseconds. While here you have your good amplitudes here with a mild delay there. So bilateral mild carpal tunnel syndrome, and the conduction velocities can be slightly slowed, but not significantly so. So that's what a typical CTS looks like. So grading of CTS, I hope all of you know, but just to go through it again: mild, moderate, severe. The moderate ones respond best to your decompression. Mild means basically only sensory involvement. Either there's just a sensory delay or comparison study abnormality, or there might be a slight drop in sensory amplitude. In moderate, the sensory amplitude will be delayed, either sort of with an amplitude drop as well as the increase in the latency. But at the same time, in moderate, the motor CMAPs will also be affected. So there will be a delay in the CMAPs, and usually the amplitudes will be normal, but there'll be an increase in the motor latency, which puts them in the moderate group, which is what we saw in the previous study. The severe ones is either the sensory and the motors are completely gone, or the sensory is gone and the motor is very reduced. And that's a severe group. So you decompress a severe group, you get some improvement in the sensory symptoms, but the motor will only improve basically with physiotherapy, while with the moderate group, you get your best responses, best outcomes. Right. So next case, describe the abnormalities seen in this study. So this is actually motor conduction studies. You can see bilateral median motor conduction, and here is your ulnar motor conduction. And then you can see that's on the left side, and you can see that's nice normal study. So that's at the wrist. This is at below elbow, above elbow. Here you can see on the right side, so distal latency is normal, the amplitude is normal. At below the elbow at the level, below the elbow at the level of cubital tunnel is also normal. But when you look at the response above the elbow, you can see that there is a drop in conduction. So this is a focal demyelination at the level of the elbow, most likely the retrocondylar groove, because that's either ulnar nerve at the elbow is compressed at the FCU aponeurosis at the cubital tunnel or at the retrocondylar groove. So that's the abnormality. Now, what sensory and motor symptoms would you expect the patient to have? They will have sensory symptoms in the little fingers, and they can have splitting of sensation in the ring fingers bilaterally. Now, sensory symptoms are not as prominent in ulnar neuropathies as they are in carpal tunnel syndromes. In carpal tunnel syndrome, patients complain a lot. Hello. Sorry. Sensory symptoms. So in carpal tunnel syndrome, patients complain a lot of sensory symptoms, while in ulnar neuropathies, they usually have motor abnormalities without. Hello.
You have to mute. themselves, please.
Sorry, okay. So question 3, what abnormalities would you expect to see in the sensory conduction study here? So now you have focal demyelination of the ulnar nerve at the level of the elbow, showing that there is a focal, sorry.
Yeah. We are trying to get everybody muted. Just hold for a minute.
Sure. I'll wait.
Dinesh Paul.
Yeah, I'm talking, sir. Then.
Please mute the other.
Shailendra? Mute ಮಾಡ್ಬೇಕು ಎಲ್ಲರೂ. Hello.
Mute ಇದೆ ಸರ್.
ಇಲ್ಲ. See the noise.
One minute.
Request all audience to mute except madam and sir.
Okay, I think we can proceed.
Okay. So question 3 here, what abnormalities would you expect to see in the sensory nerve conduction study here? So the two sensory responses that you're looking for is the ulnar snap from digit 5 as well as a dorsal ulnar cutaneous, which is here, the dorsal ulnar cutaneous, which comes off the ulnar nerve about 5 to 10 centimeters proximal to the wrist. So these are the two sensory responses you look for. But the point is, if you have such a focal demyelinating lesion without any evidence of axonal loss, if that's the case, your sensory responses may be completely normal. And the only abnormality you will find is on your motor study, which is what you find here, along with slowing in conduction velocity between these two sites of stimulation. Now, which muscles would you select for EMG? Obviously, you have to go for the ulnar innervated muscles. And because you have focal compression here, very focal demyelinating process going on here, you don't really have to look for radicalopathy or look for plexopathy or any other more proximal lesions, because this is a localizing ulnar neuropathy, not a non-localizing ulnar. Now, abnormalities in the EMG, again, you may not find much evidence of axonal loss. You may not find fibrillations or positive waves or long duration polyphasic motor units or neurogenic motor units, because this could just be a neuropraxia, could just be a focal demyelinating neuropathy. And all you might then find in the muscles innervated by the ulnar nerve in the hand would be reduced recruitment. All you would then see is reduced recruitment without evidence of significant axonal loss. Okay, so our next study, one more focal nerve lesion, and then we'll go on to some others. So this is a diabetic lady with a 10-month history of sensory symptoms in both hands, occasionally gets a symptom suggestive of a radicular pain. So electrophysiological abnormalities that you see here, let's start with the sensory nerve conduction studies. So as you can see here, the median nerve, there is a reduction in conduction velocity across the wrist. Ulnar nerve, there's a reduction in amplitude when you compare to the left ulnar nerve, which is 21 and 11.5. This is a 50% reduction in amplitude. And then if you look at the left median nerve as well, that there is a reduction in conduction velocity, and the dorsal ulnar cutaneous, there is a difference in the amplitude on the right side and the left side. So you have bilateral focal lesions of the median nerve, which are postganglionic, and the focalities at the level of the wrist, as well as what looks like an axonal lesion of the ulnar nerve, which is also postganglionic. Okay, then you go for the motor study. So you find, there's a sensory abnormality there. What is a motor abnormality? So again, there is a focal demyelination across the wrist, which is an increase in distal motor latency with reasonably well-preserved amplitudes on the right median. And on the left side, it looks normal. Left median motor response looks normal. When you look at the ulnar nerve, however, you can see there's a conduction block, stimulation above the elbow with a focal slowing in conduction velocity. Okay, so it's less than 50 meters per second across the elbow, plus it's more than 10 meter per second difference between the distal one and the more proximal conduction velocity. And that's been corroborated with the FDI, the responses from FDI as well. So what would be your overall electrophysiological opinion? Bilateral carpal tunnel syndrome. Right is moderate. Sorry. Right is moderate because you have increase in distal motor latency. And the left is mild because the left median motor responses are normal. And and there is evidence of right ulnar neuropathy across the elbow at the retrocondylar groove with secondary axonal loss as evidenced by the ulnar snap as well as the duck snap. So next case, diabetic male, 55 years old, admitted in MICU with COVID, intubated. He was there for about a week, and once he was being weaned off sedation, he was noted to have bilateral foot drop. So your upper limb snaps are normal, sensory nerve conduction studies are normal. We'll just focus on the lower limbs here from the sensory responses. So you can see the sural, this is your amplitude, sural, latencies and conduction velocities, normal. And the right sural, also normal. But you can see the bilateral superficial peroneal snaps are absent. So we go on to the motor study. So now we know it's a postganglionic lesion. We know it's a postganglionic lesion. And what is the distribution? It is a symmetrical distribution and it is bilateral. So bilateral, symmetrical, postganglionic. Superficial peroneal means there is some L5 fibers, not much S1, but some L4, L5 fibers kind of thing. So we know we're looking at something postganglionic. In which case, at this point, we immediately think, could this be, if it's postganglionic, this is either going to be a common peroneal issue or it's going to be a sciatic issue, isn't it? Or it's going to be a plexus issue. I know the sural is normal here, but these are the thoughts that are going in your mind until you do look at the motor studies. Now, in the motor studies, you can see upper limbs are all normal, no problems there. And you can see the left peroneal recorded from the extensor brevis, which is an L5 muscle, is absent bilaterally. And if you look at the tibial nerve stimulating from and recording from the abductor hallucis or from the extensive foot muscles, amplitudes are normal, latencies are normal, velocities are fine, so that looks normal. But the peroneal nerve recording from the tibialis anterior bilaterally, you can see actually that there is a reduction in the amplitudes in the C-maps recording from tibialis anterior, a possible conduction block at this level, though you can't really be sure whether that's genuine because it's such small, the less than 1 millivolt. Remember, to measure conduction block, it needs to be at least 1 millivolt, the distal amplitude, and you anyway don't have any slowing and conduction velocity across the popliteal fossa, so difficult to say that. But definitely there is involvement of bilateral peroneal nerves, or at least bilateral peroneal distributions, both distally at the extensor brevis as well as proximally at the tibialis anterior. So this still does not mean he does not have a sciatic problem, because as we know, the sciatic nerve, the lateral cord of the sciatic nerve, which is very much present at the level of the popliteal fossa there, just above the popliteal fossa, can mimic a peroneal neuropathy. So you really can't be sure if it's a lateral cord of the sciatic nerve or if it's just a common peroneal neuropathy. Could this be a lumbosacral plexopathy? Difficult to say that with such normal sural responses, but very partial upper lumbar plexopathy, we don't know yet. Only EMG will tell us about that. So localization, as we said, it's postganglionic. Distribution of abnormalities, it's L4, L5 bilaterally. And it's either we're looking at a non-localizing common peroneal here versus a sciatic lateral cord or versus a lumbar plexus. So when you do your EMG, you must remember that in such cases, that means a non-localizing pure axonal peroneal nerves always needle the short head of biceps femoris, always needle the sciatic muscles. Because if you have a very focal demyelination of the, if you just look here, if suppose you get a nice peroneal response and you can actually see focal demyelination at the level of the popliteal fossa, then you have focal demyelination there. It's a localizing common peroneal neuropathy and then everything fits. But if you have a non-localizing common peroneal neuropathy, or you have bilateral non-localizing common peroneal neuropathy, you can never be sure it's not a sciatic without needling the sciatic innervated hamstring muscles. That's important. Don't forget that. So that will be part of your EMG plan, and electrodiagnostic possibilities we have already discussed. The other question they asked was, is there electrophysiological evidence for a generalized or distal peripheral neuropathy in this study? We know the upper limb snaps are normal, so nothing generalized, and even distally nothing, because the adjacent sural response showed completely normal amplitudes. Okay, that's clear. One more thing I did not mention is, now how do you differentiate between, so now you're a short head of biceps femoris, if it's normal, then you can say that goes against a lateral cord of sciatic nerve. So it goes more in favor of a non-localizing bilateral common peroneal neuropathy. Then suppose somebody asks you, why can't it be a lumbar, pure lumbar plexus? Then what you then have to do is you have to needle a more proximal L5 muscle, because anything below the knee is peroneal or tibial. So you really can't depend on those muscles, especially if you're looking at a common peroneal neuropathy as one of the differentials. So you have to go more proximally and look for one of the proximal L5 muscles. And your choices in that case would be tensor fascial lata, very easy to needle. It's sort of at the inguinal ligament area, very easy to needle, very easy to activate. Or it could be the gluteus medius, slightly more difficult to needle and difficult to activate, actually, gluteus medius compared to gluteus maximus. But these are your options. And I like TFL. I like tensor fascial lata better because it's just technically easier for me to do. Right. So next case. So we have a 35. So we're nearing the end of a focal peripheral nerve lesion cases. So it's a 35-year-old male presents with weakness in the left hand, which he noticed on waking up. What are the key information you require prior to assessing nerve conduction study? So remember, any suspected peripheral nerve lesion, any suspected nerve-related lesion, neuropathy lesion, anything, including evaluating somebody for radiculopathy also, duration is important. So you need to know when did the symptoms begin, because you don't want to do a nerve conduction study too early, because you'll miss it, and then you'll say everything is normal. Or, so that's basically the reason you need to know the duration of symptoms. Now, nerve conduction studies, so if you can see up here, they all look normal. I don't want to go through each one because it's quite a lot. And the reason, sorry, one more thing I didn't tell you, the reason I put up these kind of lab looking, I didn't type everything, all the data out. I put up these kind of sheets because this is probably what you will be handed during your exams, for the exam going students, you'll be given a sheet like this and said, okay, go through the data and tell me. So I don't want you to be faced by the data. So first, orient yourself. When you get the sheet in front of you, orient yourself. What are you looking at? Upper limbs, lower limbs. So where's your right? Where's your left? And then slowly work your way down. Take your time doing it. So this is what it will look like. It'll be a little bit folded and all those things. Okay. So if you look through everything, all this is looking normal. Superficial radial is looking normal on the right side. So once you've seen a right nerve, immediately go to the opposite side, same nerve. So go to your left superficial radial and, oh, that looks abnormal. So that amplitude is more than 50% reduced. So there is an abnormality that you've noted in the sensory nerve conduction study. Then look at MABC, left MABC normal. Right LABC amplitude 64, left LABC normal. So axonal is what we're looking for here. Left digit 1 and then right digit 1 is normal. So go like that, and actually everything is normal apart from the left superficial radial snap here. Now, I just want to comment on the radial nerve. So when you study the radial nerve in the context of the upper limbs, where brachial plexopathy is one of your differential diagnoses, the radial nerve actually can be involved in upper, middle, or lower trunk. So in the superficial radial snap actually has more of C6 fibers in it than C7 or C8. So it can easily be involved in an upper trunk lesion, while the radial C-map can easily be involved in a lower trunk lesion. So it's like the changeling, it's like the fickle nerve where it can just move around. So if it's abnormal, it doesn't always mean a middle trunk. If it's abnormal, then you immediately must look for the upper trunk. Is there any accompanying upper trunk abnormality, or is there any accompanying lower trunk abnormality? Middle trunk is always difficult. Middle trunk is very difficult. You'll end up relying on EMG for middle trunk because there is so much, overlap. So when you see a superficial radial snap looking like this, you immediately go and look at your digit 1. So we'll go through plexus in a minute, but digit 1 is C6. Digit 3, your middle finger, is C7. And digit 5, your little finger, is C8. The maximal fibers are in these 3 digits. So you immediately go up to your digit 1 and see that actually that's not affected. So C6 is not so affected. Then you go to your digit 7 snap, your ulnar snap, which is your medial cord or lower trunk, and you see that's also not affected. MABC is not affected. MABC is medial antebrachial cutaneous, which comes from the medial cord or part of the lower trunk, or the lateral antebrachial cutaneous, which comes from the upper trunk lateral cord, that is also not affected. So you have a pure superficial radial. So when you have a pure superficial radial snap that is affected, and the rest of the snaps are not affected, you're either looking at a radial neuropathy or you're looking at a posterior cord lesion. Okay, so radial neuropathy or posterior cord lesion when you have a pure superficial radial snap that is affected. So let's go to the motor studies. Again, your medians are fine. You can go through that. Amplitudes are okay. Velocities are fine. Latencies are okay. Amplitudes ulnar are fine. Everything is okay. And then you get your left radial C-map. And you can see that the right radial CMAP looks normal. Left radial CMAP, there is a reduction in the amplitude, and that's recorded from the EIP or extensor indicis proprius. So it's distal axonal loss. And there is a conduction block just above the spiral groove. Okay, so there you go. That's fine. Now, so this now your localization, we know it's postganglionic. We know it's focal. So your localization is postganglionic. Your distribution is focal. And then your characterization is more axonal. Your characterization is axonal. It's demyelination. My fault. Sorry, demyelination. It's focal demyelination there. So you actually have enough there. You can actually stop there. You can stop thinking further there. But it will always be good practice in such cases to make sure that you have excluded a posterior cord as well. And the posterior cord you exclude through EMG. And one of the best muscles for posterior cord exclusion is your latissimus dorsi. And it's a good muscle to learn to needle, because that will tell you, because the radial will always be present, in a plexus lesion, which is even slightly upper trunk, lower trunk, the radial will come somewhere and be abnormal. And then you'll have to prove when you give your report that you have excluded a posterior cord lesion, because radial snap is very much involved in posterior cord lesion. So currently all we are finding is a postganglionic focal demyelinating lesion of the left radial nerve. There is secondary axonal loss. And as I said before, you have to EMG the radial muscles because you want to know how severe it is. We know it's not a neurotmesis, it's an axonotmesis, because there are some amplitudes, some distal amplitude that we can record. So you still have to do the muscles to see how much reinnervation has happened. And obviously you have to exclude a posterior cord lesion by EMGing the deltoid as well as a latissimus dorsi. Okay, hope that is clear. I haven't done a latissimus dorsi here. It's being lazy, I think. I just did a deltoid and didn't find anything there, so left it at that. So you can see the active denervation in the brachioradialis, EDC, and EIP. So it's at the level of the spiral group, left radial nerve, at the level of the spiral group, postganglionic focal demyelinating lesion. Okay, and there is no signs of reinnervation currently, but there are still some motor units, and there is active denervation. So we'll have to repeat the study to see how much recovery he will get later. Okay. So the other thing I had asked in the previous slide, I think, was so timing of study from onset to symptoms. Remember, onset to symptoms is very important, as I said before. If you do a nerve conduction study in a suspected lower motor neuron lesion, within 1 week, it will be normal, and you will be frustrated. You won't know what is happening. Patient will be frustrated because they spent all the money and you have not told them what to do. So you've got to be careful. You've got to be really careful about the timing of it. So as we said before, left radial nerve lesion, localized to spiral groove, it's focal lesion, secondary axonal loss, it's a partial lesion, it's axonotmesis, not neurotmesis, because you still have amplitudes there, and there is no significant reinnervation that you can see, and there is no evidence of involvement in the brachial plexus. Mainly the posterior cord is what we were thinking about here. Okay. So that ends the focal peripheral nerve lesion section of it. Any questions that anybody has, or shall we carry on?
Well, no questions have been put on.
Okay, so fine. Right, so let's go to plexus. So plexus is always fun because especially brachial plexus, and I have actually focused much more on brachial plexus than I have on lumbosacral plexus. Lumbosacral plexopathies are rare, relatively rare, while brachial plexus is much more common, and you'll be called upon very often to assess the brachial plexus. So this is a good sort of slide to remember, because this really has everything in it. So if you look at the upper trunk and lateral cord, I'm not going through, by the way, what is the upper trunk, middle trunk, lower trunk. I'm presuming that you know all that. You've already looked at all these things. I'm just giving you the clues that you can use in your assessment. So in the upper trunk, you have to do the LABC. 100% fibers of the upper trunk, LABC is fed by the upper trunk. The median thumb, 100%. Superficial radial, 60. So I told you about the superficial radial. Listen, it can be abnormal in the upper trunk, and it can be abnormal in the middle trunk. And as you can see, very interestingly, there are many more fibers of the upper trunk in the superficial radial than the middle trunk in the superficial radial. It's a big nerve. Okay, but the most important time when the superficial radial will be affected is either in a radial nerve lesion or in a posterior cord lesion. So otherwise, for the upper trunk is always lateral antebrachial cutaneous nerve, which is sort of lateral here, and then the median thumb, which is C6 thumb. So this is superficial radial. These are your upper trunk snaps. From a lateral cord point of view, it is again LABC and median thumb. From a middle trunk point of view, it is the middle finger, sometimes index finger. Index finger has more C7 than C6, but middle finger is important to do. And the superficial radial, if you're looking at the posterior cord, as we discussed that before. So with the lower trunk and medial cord, same snaps. You're looking at the ulnar snap from the little finger and the MABC. MABC is a medial antebrachial cutaneous here, and the same goes to the medial cord. So very difficult to differentiate between lower trunk and medial cord. One way to do that is through your radial C map. So radial C, there's more chance of a radial C map showing an abnormality in lower trunk than there is of a superficial radial snap showing an abnormality. So if you have all your abnormalities in the lower trunk and medial cord region, but along with that your radial C map is reduced, then that's still lower trunk. It doesn't mean it's middle trunk unless you find something else on EMG. So same goes with the C maps. C maps wise, upper trunk, lot of things you can test. You can test the supraspinatus, you can test the muscular cutaneous nerve recording from the biceps, axillary, deltoid. So both upper trunk and lateral cord, that's helpful. Middle trunk, it's actually radial nerve from Anconis, which we don't routinely do, but Anconis is an easy muscle to needle, and it's an easy muscle to also test from. It's on the sort of lateral side, if you can see here, between my lateral epicondyle and my olecranon. That's where the Anconis is, and you can sort of pronate and you can get an extension, extension, and you can get the belly of the muscle. So that's the only real reliable CMAP study for the middle trunk. But for the CMAP for the middle trunk. For the posterior cord, you can do the axillary, and you can do the radial nerve. You can do either EIP or extensor communis. From the lower trunk point of view, it's the ulnar from abductor digiti minimi and median from abductor pollicis brevis, or ulnar from F1 dorsal introsseous is also fine. And also, like I said, radial from extensor indicis proprius. That might still be abnormal in the lower trunk study, but it will not be abnormal in a medial cord study. So how would you differentiate between lower trunk and medial cord? Using the radial CMAP recorded from EIP. So these are all your muscles. You know these muscles, I'm sure. I mean, upper trunk will be your spinatus, biceps, deltoid, and in the forearm, you look for pronator teres and flexor carpi radialis. These are all good upper trunk muscles. Middle trunk will be again forearm, and the radial muscles, triceps will be part of middle trunk. The lower trunk will be abductor pollicis brevis, first dorsal introsei, and some of the lower forearm muscles, like flexor pollicis longus. It's an easy muscle to needle. It's quite a good one. Extensor pollicis brevis, all those ones. Lateral cord is biceps, pronator teres. Posterior cord, remember, latissimus dorsi, deltoid. But deltoid can be involved in upper trunk, and triceps can be involved in middle trunk. While latissimus dorsi will only be involved in posterior cord. So that's one way to differentiate between middle trunk and posterior cord in EMG or latissimus dorsi. So medial cord, again, abductor pollicis brevis, first dorsal introsseous, and your distal forearm ventral aspect muscles. Right, so let's go for a case. 51-year-old male, known history of cervical spondylosis and multi-level radiculopathy. He has a history of spondylosis. He wakes up in the middle of the night with pain over the base of neck on the right side. Within a week, he notices difficulty in lifting the right arm. And studies were undertaken about 2 weeks after onset of symptoms. So clinically, what you're thinking, we know that he has a history of cervical radiculopathy. So it could be cervical radiculopathy, but it woke him up in the middle of the night. It was not during the daytime, not while he was doing the exercise. So the one thing we need to think about always in such cases is neuralgic hemorrhage or brachial plexitis. So these are the two clinical possibilities that we have here. So let's look at the nerve conduction studies. So you have your ulna is looking normal, snaps are looking normal. Your median, left median is fine. Left median, only have to change the left median there. 22.5. Actually not able to see the top. Sorry, one second. So you have a LABC here. And let's look at the LABC on the opposite side. So the LABC on the right side is reduced. So you have a postganglionic lesion there. MABC you can see there. And then the MABC is not involved. So there's no involvement of the lower trunk. Then you have your median digit 3 and your digit 3 here on the left side, on the normal side. As you can see, there is an involvement here. And then your superficial radial here, which is the affected side, right side, and the left superficial radial here, you can see it's involved there. So you have involvement of digit 1, you have involvement of digit 3. So when you have involvement of digit 1, snap from digit 1, then you know it's already upper trunk. You have digit 3, then you have a possible middle trunk. But remember, digit 3 also may have a little bit of upper trunk involvement. Then you have a superficial radial snap, but you know the superficial radial snap can be affected in upper trunk lesions as well. And LABC, as you know, is part of upper trunk. So you clearly have upper trunk involvement here, quite clearly. There could be a middle trunk involvement, you're not sure, but definitely it's postganglionic. It's not a radiculopathy, it's postganglionic. So immediately, it helps with the etiology immediately. So you go to the motor studies. The only abnormality on the motor study here is the upper trunk C-maps. So if you see all the muscles that are from the upper trunk lateral cord, you can see the amplitudes are reduced on the affected side, the right side, compared to the unaffected side, the left side. And the rest of the amplitudes are normal. Importantly, the radial C-map is normal. So there's no involvement of lower trunk as well. So now it's looking more like an upper trunk lesion, isn't it? It's looking more like an upper trunk lesion, but you had that involvement of the C7, the digit, middle finger digits snap. So you're not very sure now whether middle trunk is affected or not. So when you do your EMG, you can see deltoid is upper trunk, biceps is involved with fibrillations of posterior waves, that is upper trunk. Triceps is involved, and that's more middle trunk. And triceps is quite significantly involved, a lot of reduced recruitment and active denervation. Infraspinatus is upper trunk. So now that looks like an upper trunk with definitely some involvement of the middle trunk there. So what our clinical diagnosis was neuralgic hemiptrophy versus cervical radiculopathy, but because of involvement in the snaps, we localized lesion postganglionic to level of plexus. So etiology-wise, neuralgic hemiptrophy would be more likely. And then right brachial plexopathy is our final diagnosis. Definitely there is a upper trunk involvement, partial involvement, but there's also middle trunk involvement. That's also partial involvement. So a posterior cord, you could argue, but there is definitely middle trunk involvement as far as triceps is concerned. And it's important, actually in this patient, it's important to do a latissimus dorsi as well, so you can prove that there's no posterior cord involved. So that's how you work it out from your snaps. The snaps are quite easy, actually. From the snaps, it really give you a clue. And don't be faced by finding a radial C-map that is affected in somebody who has otherwise lower trunk lesion. Okay, so 45-year-old male with fracture dislocation, left shoulder, humeral fracture, traumatic, and the study was undertaken 1 month after injury. So abnormalities and sensory nerve conditions. So we'll start with snaps first, because we need to localize it. Are we looking at preganglionic? Are we looking at postganglionic? So that's important. So the abnormality, So the only abnormality we have is the left superficial radial snap is showing a reduced amplitude. So if you look at the rest of the snaps, I'm not going through each one, but the rest of the snaps are normal. The rest of the snaps here are normal, but the only thing we have is the left superficial radial is reduced compared to the right superficial radial. So again, we don't know whether that is a superficial radial only or a posterior cord as well, because we know he has a humeral fracture. He could have a brachial plexopathy as well. But the upper trunk is not involved. We know that because all the LABC and digit 1 snaps are normal, and the lower trunk is not involved because the MABC is normal and the ulnar snap is normal. So when you look here in the motor conduction studies, what you have is actually two things. You have your left radial C-map, which is completely absent. So if that was the only thing, you would still be left with thinking, could this be a posterior cord versus radial neuropathy? But you also have a left deltoid involved, partially involved. Again, the two possibilities here remain the same, because the axillary also comes from the posterior cord. So this could still be a posterior cord lesion, or it could be two separate nerve lesions. And the only way to find out here would be to EMG the latissimus dorsi. So the EMG studies just show denervation, as you can see there. There is no involvement of the triceps, there's no involvement of any of the upper trunk or the middle trunk, but there is definitely involvement of the axillary as well as a radial. Now you need to know whether there is involvement of latissimus dorsi, which will help you differentiate between upper trunk versus posterior cord. So that's So that's the bit that you need to do before you can be sure that these are two separate nerve involvement. We know it's two separate nerve involvement later because eventually when he was operated, they found that the nerves were affected bilateral. Both nerves are separately affected. But under ideal circumstances, this could still be posterior cord unless you do the latissimus dorsi to prove that it's not. Okay. So we're nearing the end of the brachial plexus one. So this is a young lady with a 2-year history of weakness and wasting of the right intrinsic hand muscle. So this is, I've typed up all the values here. So as you can see, the median snaps are normal from digit 2. The ulnar snap, as you can see on the right hand, is actually reduced compared to the left side. And then the superficial radial is normal. And the MABC is interestingly normal. MABC is also medial cord, lower trunk. That's also normal. The only abnormality here in the sensory study is the abnormal right ulnar snap. Then when we look at the motor studies, the only abnormality is the right median recorded from the APB, which is a medial cord lesion, and the right ulna, which is also a medial cord lesion. So that's a C8 primarily from abductor digita minimi, and this is a T1 from abductor pollicis brevis. So these are the only two abnormalities. So it's postganglionic and it is very focal. Okay. And it's at the level of C8. So it's postganglionic C8 T1. That's what we are finding. The ulnar snap was normal. This would be a preganglionic C8 T1. And important to see that you can differentiate that it's not lower trunk, that it's actually just a medial cord, because as I said before, the radial C map is normal. The radial C map on the symptomatic side is normal. So EMG also shows similar findings with just the FDI and the APB denervated, as you can see there. So it's actually a right partial medial cord lesion with active on chronic denervation or axonal changes. And this lady turned out to have a cervical neurogenic thoracic outlet syndrome. So NTOS can be quite difficult because there was a recent study, I think in muscle nerve, where they found that out of their 14, 15 patients, only half or less than half of them actually had the full picture of the electrodiagnostic pattern, which is the median snap will be normal because it goes to the upper trunk, and only the medial cord or the lower trunk will be affected, mostly the medial cord. Now, the interesting thing here is the MABC was not affected, but you will never get the full pattern. So that's important to have a high degree of suspicion whenever you see a postganglionic lower trunk in a relatively young person, and usually a female for some reason, they tend to get this more often. Okay, so this is a patient who's had trauma and he has noticed weakness in the left upper limb, and it's been 7 months now. So the sensory nerve conduction studies are normal. I've already told you sensory nerve conduction studies are normal, so immediately becomes preganglionic. And so you think, would this be preganglionic? So in the motor conduction study, the only abnormality we have is at the level of the upper trunk. So the biceps recording, so the muscular is recording from biceps, axillary from deltoid, and the suprascapular from the supraspinatus. The amplitudes are much reduced compared to the right side. While if you look at the rest of the amplitudes here, they look normal. So whenever you see something like this, I've told you the sensory nerve conduction studies were normal, but what are the sensory nerve conduction studies you would be interested in? Obviously, you would be interested in digit 1, median digit 1 snap, because that's C6. And you'll also be interested in the lateral antebrachial cutaneous snap. So these two will inform you about a postganglionic upper trunk lesion, a postganglionic C6 lesion. And remember, C5 does not have any snap, so you cannot say if it's pre or postganglionic. You can never be sure about C5, whether it's part of the plexus or whether it is the lesion is preganglionic at the root level. So EMG also shows a lot of denervation. So all we have is CMAP, abnormal CMAPs, and the EMG is also showing upper trunk involvement, deltoid, biceps, infraspinatus, and the flexor carpi radialis, which has C6 and C7, brachioradialis. All these are involved. So we have preganglionic localization of the left C5 and C6, and the lesion is proximal to dorsal root ganglion, and this patient actually turned out to have a cervical root avulsion. Now, interestingly, we did do the paraspinals, which were normal, and it can be normal. And we also did the dorsal rhomboid, which is supplied by the C5, dorsal scapular nerve, the C5, and comes straight from the C5 root, a little bit of C4 also, but C5 root, and that was also normal. So the two problems, there could be two problems here. One could be that just it's patchy and it was normal and was a false localizing sign. Secondly, the dorsal rhomboids lie under the trapezius, middle fibers of trapezius, and it can be difficult to get to the dorsal rhomboids, and it might be sometimes difficult to activate it properly. So it could be that I was in the trapezius rather than dorsal rhomboid. So this shouldn't put you off. That's what I'm saying. So you will go very carefully looking for preganglionic lesions, avulsions and things, but you may not get that full picture because of various technical factors. But you have normal sensory responses. You have CMAPs that are affected. You have active denervation in those regions. So you have preganglionic enemy. Quickly, just one case on lumbosacral plexus. Lumbosacral plexopathies, luckily, are much rarer than brachial plexopathies because they are very difficult to diagnose because they tend to happen in elderly people, and elderly people's sensory responses in the lower limbs are difficult. They might have coexisting neuropathies. The responses themselves will be very small, and they might be difficult to actually do, technically also difficult to do. They might have some pedal edema, in which case you can't get the responses reliably. So all those things. But this table, I think we'll get it in Shapiro anywhere, but this table is like just how do you differentiate multiple lower limb issues, lower limb LMN issues, and just the things about differentiating between sacral plexopathy and lumbar plexopathy to look for postganglionic lesion or to look for any abnormality, lumbar plexus abnormality on nerve conduction studies. You really don't have many tests. You only have the femoral motor response, which is technically difficult. You have the saphenous snap, which can be abnormal, which can be absent in somebody who is elderly anyway. And you have the lateral cutaneous nerve of thigh, which is L2, L3, L4, directly from the plexus, which it can be very difficult technically to do. So these are the only reliable nerve conduction study responses for lumbar plexopathy. So you can see how difficult it is. So sometimes you end up relying completely on EMG. From a sacral plexus point of view, you have all the rest of your routine nerve conduction studies in the lower limbs come primarily from the sacral plexus. So you have all these various modalities which you can do for the sacral plexus, and those are probably slightly better than the lumbar plexus for localization, easier to find, technically easier. So when the plus here means involved, so that's good. So EMG, you end up relying on EMG. So make sure that you have an EMG muscle that you like for L2, L3. What do you like? L3, L4, which one would you use? Vastus. L4 predominant would be tibialis anterior, vastus lateralis. L5, these are your options. The extensor hallucis longus and flexor digitorum longus, these are quite easy to do. S1 gastrocnemius, gluteus, but gluteus is a big muscle. If it's patchy involvement, you might miss it. A short head of biceps femoris for L5S1, or lower lumbar paraspinals, you can select wherever you want to do. And so if you want to look at the sacral roots, you can do external anal sphincter. Uncomfortable soleus is quite good for S2. Foot muscles, but foot muscles may be abnormal without having, without a real pathology in elderly people. So it's very difficult, lumbosacral plexopathy, but you need to end up, basically clinically, you will have a very high suspicion. So then you look for it very carefully. Otherwise, only if you look really carefully, and then only then you'll be able to diagnose something like that, and you will rely heavily clinically on your clinical findings rather than electrophysiological findings. So just as one case on lumbosacral plexopathy, so it's a diabetic male, female. She's also had a history of hysterectomy and radiotherapy. And she had now presents with left lower limb sensory symptoms with absent reflexes, ankle reflexes, reduced left knee reflex. And so basically there is asymmetricity in the clinical examination. So although there is bilateral ankle DTRs which are absent, suggestive of a distal symmetrical peripheral neuropathy, there's also some asymmetricity with reduced left knee DTR. Then immediately you start to think, now there is something else, there's something more proximal. Is it a plexus? Is it a root? So you think about it then. Okay, so when you look at the nerve conduction, sensory nerve conduction studies, remember we start with the snaps. The upper limbs are normal. The superficial peroneal is slightly on the smaller side. I know she's 60, but it's still on the smaller side. Sural, it's a bit borderline. It's not too bad on the right side, but on the affected, the symptomatic left side, basically they are absent. So there is asymmetricity. Immediately, you know it's postganglionic. Second, you know that is asymmetric. Okay, and you go to the saphenous. Saphenous mostly is L3 and L4, and saphenous you see that the amplitude is reduced. So 5 microvolts you would like. At 60 you can get 5 microvolts. It's only when it goes about 70, 80 it becomes difficult. So 2.2 is on the smaller side in saphenous, and then you have on the left side, though it is not at all. It is inexcitable. You couldn't even get the saphenous. And somebody has very bravely done the lateral cutaneous nerve of thigh, which is absent on the affected side, left. On the right side, it's within normal limits. That's okay. So you have abnormalities. So you have postganglionic abnormalities in both legs and at sort of L4, L5, S1 level, if you want to put the dermatomes on it. But there's also asymmetricity, with left being more affected than the right. So this is where you start suspecting your plexus. Anyway, clinically, that's what you're doing. Clinically, you will suspect plexus in this case. But this is your clue, and this is a good enough clue. Yeah. So motor-wise, you have your upper limb motors are normal. And then you go to your lower limb motors, right? Peroneal is also slightly reduced. Tibial is borderline. But left, you can see, is asymmetrically involved, quite severely involved. And femoral motor study, very difficult to do, but somebody has done it, shows reduced amplitudes on the left side. So there's asymmetricity between that. So again, now you know that there is something proximal going on along with her peripheral neuropathy. You, as I said, you rely on EMG. So as you can see in the EMG, there's quite a lot of active denervation in the L4, L5 TA. TA sometimes has more L4 than L5. Gastrocnemius, gluteus L5, vastus lateralis with a bit of L4. So the left-sided muscles are much more severely denervated. The right muscles are also denervated, but they're more chronic denervation with partial renervation, which is probably related to her underlying peripheral neuropathy. The other thing that has been done is the lumbar paraspinal muscles. There is no evidence of active denervation to suggest a radicular localization, but you have to take that with a pinch of salt because the paraspinals can be quite difficult to needle. And if it's patchy involvement with multiple innervation, paraspinals have multiple, you never know where L4, L5 is clearly when you do the EMG, because L4, L5 could have a bit of S1 in it, a bit of L3 in it. So it's very difficult to be sure. So just because the lumbar paraspinals are normal, just because paraspinal muscles are normal, does not exclude a radiculopathy. That's what I was trying to say. Okay. So localization is postganglionic. Dermatomes, myotomes involved, L4, L5, S1, because superficial was involved, saphenous was involved, and sural was involved. And it was asymmetrical. It was involved bilaterally, left more than right. So diagnostic opinion, postganglionic left L3, L4, L5, and S1. Mild postganglionic involvement of L3, L4, L5, and S1 on right side. This is your actually technical group. But then that translates clinically into unilateral lumbosacral plexus involvement because the snaps are involved here. And you could argue that the paraspinals aren't involved, but the paraspine, if this was a diabetic radiculoplexor neuropathy, the paraspines also might be involved, but that doesn't mean she doesn't have a plexopathy because the snaps are also involved. So it could be a radiculoplexitis in such cases. So a diagnosis here will be a left lumbosacral plexopathy with a distal sensory axonal peripheral neuropathy. So two pathologies. So this is where I said the lumbosacral plexopathies can be slightly more challenging compared to the brachial plexopathies. So that's it. We're on to our last section. Dr. Sharma, do we carry on, or I think I've gone beyond time as well?
Okay. Two cases. We can
just a few more cases. So here I thought I'll just talk about our typical axonal neuropathies, demyelinating neuropathies, and then just finish off with one or two extra cases there. So electrophysiological criteria for demyelination. I wanted to put the slide here. This is easily available anywhere online, any of the textbooks. Dumitru, no problem. This EFNS is the European Federation of Neurological Societies. For the residents who are going for the exams, you need to be aware of this criteria. You may not be able to remember everything, but you need to be aware that these criteria is what we use when we diagnose demyelination in the peripheral nerves. Now, these criteria, that's for the exam. But these criteria are really helpful, especially when you have somebody who has demyelination with severe secondary axonal loss. So you don't know, is this, which came first? Is it axonal followed by some slowing in conduction because of loss of fast conducting fibers? Or is it actually primary demyelination with secondary axonal loss? Or is it a mixed axonal and demyelinating where you can't differentiate the two? And this mixed axonal and demyelinating picture, you really see in two clinical scenarios. One is your diabetic patients. So diabetic patients tend to have a mixed axonal demyelinating neuropathy, unless they have a full-blown CIDP, obviously. But that mixed axonal demyelinating neuropathy in a diabetic patient should not be misinterpreted as CIDP. So that's important. Sorry, the light went off a little bit, but that's important. So don't diagnose that as a CIDP. So it's important. These criteria will help you make the differentiation between mixed axonal demyelinating and primary demyelinating neuropathies. The other time when you can have a mixed axonal and demyelinating picture is in early GBS. So early GBS in the first 2 weeks, you never get a clear primary demyelinating neuropathy. You'll be very lucky to do so, even if it's an AIDP. So you'll always get a mixed picture. So electrophysiological criteria, I put it up here, going through everything. So 2 motor nerves. Like I said, we rely on the motor nerves, and 2 motor nerves is what we rely on for distal latency prolongation, reduced conduction velocity, abnormal temporal dispersion, and motor conduction block. So that makes it definite. If you are relying on F waves, then you have to have 1 more nerve with either increase in distal motor latency or reduction in conduction velocity or abnormal temporal dispersion or conduction block. So that's important. This you can get anywhere. Exam going students, you can get anywhere. It will be a good thing to actually put it up in your lab. Just stick it up on in a notice board in your lab, because suddenly you have this patient, you have to produce a report immediately and you are not sure now. All these values are there, and this will really help you. Okay, so case, 25-year-old man with paresthesia in hands and feet, proximal and distal weakness of upper and lower limbs, bifacial weakness, areflexia. So very acute onset peripheral neuropathy by the sounds of it. Nerve conduction studies were done 2 weeks after onset of symptoms. So let's go to the abnormalities straight. So here we have medians are absent. So, but medians are always unreliable because there could be a superimposed carpal tunnel syndrome. 25-year-old man seems less likely, but if you have an elderly person with just median prolongation or conduction loss syndrome, be very careful. You are not supposed to actually diagnose based just on that, because it's such a common site of entry. But in his case, he actually has reduced amplitudes of the ulnar snaps with reduction in conduction velocity and increase in latency, while the sural snaps in the lower limbs are within normal. So this is the pattern that you would have all heard about, the sural sparing pattern, or the dichotomy between the upper limb and the lower limb sensory responses, which usually points to an acute demyelinating neuropathy. Now, there are arrows everywhere in the motor studies. All the motor studies are abnormal. So you have increased distal motor latency. Again, you can't rely so much on the median CMAPs, because they could be part of a carpal tunnel picture, and we will be confusing your picture here. But if you look at the ulnar, there's increase in latency, 3.5 milliseconds, and it's 4.9 here. There is reduction in the amplitudes. So this is what I was saying about a mixed axonal and demyelinating picture. So even the amplitudes are reduced, and the conduction and the distal latency are not that prolonged. So distal latencies are not that prolonged, but the amplitudes are definitely reduced. So you actually have a mixed axonal and demyelinating picture here. F waves are absent, and F waves, as you know, one of the first things to go. H reflex and F waves are the first things to go in AIDP. As you know, this is an AIDP case, but how you would characterize it would be a mixed axonal and demyelinating neuropathy with conduction block, as well as sural sparing. In this clinical context, so that's how it comes. In this clinical context, this would be suggestive of an acute inflammatory demyelinating polyradicular neuropathy variant of GBS. So that's how it should come. So everything in the clinical context, as I said before. So next case, 59-year-old diabetic male. He's been having sensory symptoms in his feet, suggestive of a peripheral neuropathy. Then it has progressed to his hands. But in the past 3 months, he's had something more acute. He has noticed more sensory symptoms, as well as weakness in the right hand and in the right foot. So there is clearly some pathology that is long-standing, and then there is something very acute that is going on here. So what are the sensory nerve conduction study abnormalities? As you can see, your lower limb snaps are completely absent. Lower limb snaps are completely absent. Upper limb snaps are absent partly and severely reduced here in the median. The conduction velocities are not too bad. So we know now, and the superficial radial is also reduced in amplitude. So we know now that this is a postganglionic lesion. So because the snaps are involved, so it's postganglionic. What is the distribution? It's generalized. It's not just in the lower limbs, it's in the upper limbs as well. So it's generalized. So it's a symmetrical, asymmetrical. According to the snaps, sorry, I keep doing that. According to the snaps, it is symmetrical. So you have postganglionic, generalized, symmetrical. You won't be putting all these things in the report, but these are the ways you will think about it in your brain, so that as it progresses, you can then start slotting it. So when you give the report, it'll be a coherent report. From a motor study point of view, lower limb motors are absent. Upper limb motors are reduced. Upper limb motors, especially the right ulna, is reduced. You can see the right ulna is reduced, but the conduction velocity is normal, while the rest of the upper limb motors are normal. The tibial here is reduced, while the left tibial is normal. So in the foot where he was giving his maximal symptoms, that is the right foot, remember bilateral was chronic, but the right foot where he had the more acute symptoms, there's definitely an asymmetricity going on. So in the distribution, you will add not just generalized, you'll also say that there is an asymmetrical involvement of the right ulnar nerve and the right tibial, or right common peroneal nerve. Now, without doing EMG, you cannot be sure that it's actually nerve. You will have to do other C8 muscles. You have to needle other C8 muscles to prove that there is nothing more proximal, like root involvement, because the snaps are not helpful to you. The snaps cannot help you localize the right-sided lesions because the snaps are very severely affected, likely due to his underlying neuropathy. So you might end up needling to exclude other C8 lesions. So these are the abnormalities in the motor study. Distribution, as we explained before, focal versus generalized, symmetrical versus asymmetrical. At EMG is now going to be very key in this case, because EMG has then proved that it's the ulna. The denervation is in the ulnar distribution. And although there is some mild chronic denervation in the less symptomatic left lower limb, the right lower limb is showing much more severe denervation. And other regions, FDP digit 4 and 5, all the other muscles are normal. There's no evidence of any sciatic involvement. So then you have a symmetrical sensory motor axonal length dependent peripheral neuropathy. That will be your final coherent diagnosis. And superimposed right ulnar and common peroneal neuropathy, suspicious of a mononeuritis multiplex. So eventually what you're looking at is a mononeuritis multiplex superimposed over the background of a peripheral neuropathy. Now, if suppose the peripheral neuropathy symptoms are also very recent, it could all be part of a confluent mononeuritis multiplex, but it sounds like the peripheral neuropathy in a diabetic patient was long-standing and it was going on for 2 years. So that could be separate from the new pathology that is happening. And this gentleman actually turned out to have Hansen's disease on nerve biopsy. So this is how you interpret the different aspects of it, and then you're able to then put together a coherent report. So one more. This is a lady who's been having quite recent symptoms.
Sensory 0.
2 months with loss of balance. Yes, sensory is 0. She's currently on treatment for multiple myeloma. And you look at the chemo drugs that she's on bortezomib and thalidomide. All of them can affect the sensory responses, as you know. So what is your localization? It's postganglionic, and all the sensory responses are affected. And look at the motors. The motors are so abnormal from a demyelination point of view, isn't it? The amplitudes are reasonably well preserved, but the distal motor latencies are so severely delayed. Conduction velocity is severely reduced. You can see all the conduction velocities here, all of them severely reduced. Conduction block, possibly in 1 or 2 sites, but really it's just such severe axonal loss. So primary demyelinating neuropathy with axonal loss. So postganglionic, generalized, symmetrical, and your final characterization, axonal versus demyelinating, would be demyelinating. So what may be the reasons for the sensory abnormalities? So the thing is, we know that she has multiple myeloma. We all know that multiple myeloma is associated with paraproteinemic CIDP. So this could very well be a paraproteinemic CIDP. We know that because there is demyelination, and we know that that can be part of the myeloma. But the severe sensory abnormalities could also be due to the bortezomib and the thalidomide. Thalidomide itself will cause very bad sensory neuropathies, while the bortezomib can actually cause dorsal root ganglionopathy as well, so degeneration of the DRG. So that could be the reason for such severe sensory involvement. Very difficult for us to say. But if somebody asks you what could be the reasons for such severe sensory abnormalities, in her case, it could be the chemotherapy, the agents that are used, and secondly, the CIDP itself can cause this. So 25-year-old male, sorry, I'm hurrying through these cases, 10-day history of imbalance, weakness in both lower limbs, and difficulty using his hands since past 1 week. So here again, we have another possible acute neuropathy, just like we had the AIDP before. And nerve conduction studies are actually normal in his case. So if you look at the amplitudes and the conduction velocities, latencies, 25, 26, 45, they're all normal. The lower limbs are normal, upper limbs are also normal. But if you look at the motor studies, they are abnormal. So you have the motor responses are reduced. So it's an axonal pathology with conduction velocities are normal here. And you can see again the axonal pathology. So it's a generalized axonal pathology. So you would be tempted to think it's preganglionic because your snaps are normal. But whenever you have this sort of a scenario, when the snaps are normal and the C-maps are abnormal, you are really looking at this bit. So reduced C-maps and normal snaps, it could still be motor axons. So obviously, it could be preganglionic with root, anterior horn cell being involved, presynaptic neuromuscular junction, and very severe myopathies like polymyositis, generalized polymyositis. But remember, you can have just pure reduced C-maps in peripheral nerve lesions like a motor axonopathy. And when you look at this clinical, again, always you have to connect it with the clinical symptoms. It's very acute clinical onset. This could be AMAN, acute motor axonopathy, axonal variant of AMAN variant of GBS. So although the snaps are normal, reduced C-maps, along with being a preganglionic, along with giving you a preganglionic localization, can also give you a motor axonal localization. So don't forget that. And again, you'll have to think about what you are looking at from a clinical point of view here. Now, paraspinal EMG will also help you differentiate between root versus anterior horn cell. But in this patient's case, as you can see here, it's only been 1 week. It's only been 1 week, so your EMG is going to be normal. The only thing you're going to find on EMG is reduced recruitment. You will not get any active denervation changes, so that paraspinal EMG will also be useless. So this is where in GBS, eventually you go back to your clinical history and your clinical examination, and you might just have to give him immunosuppression after a CSF study or whichever way you could do it. But this is the thing, just because your C-maps are reduced doesn't always mean it's preganglionic. It could also be motor axonopathy. 66-year-old diabetic man, paresthesia in feet followed by hands, progressive 12 months, presence of difficulty in opening jars, bilateral foot drops. So distal weakness, he's areflexic, nerve conduction abnormalities, as you can see here, quite severe nerve conduction abnormalities. All the lower limb snaps are gone. Upper limb snaps are showing increased latency with reduced amplitude. Some of them are absent. So there is primary demyelination with secondary axonal loss. And you can see the same thing in the motor studies. So diabetic patient, it's postganglionic, it's generalized. There is some degree of asymmetricity, but it's relatively mild, a little bit of asymmetricity, but it's relatively mild in the larger scheme of things. And it's demyelinating. The characterization, the final characterization is that it's demyelinating. You have your conduction velocities here, you have distal motor latencies, you have F-wave abnormalities. So this looks like primary demyelinating neuropathy, and CIDP would be top of your priority as long as you have excluded a paraprotein. So we've talked about temporal. This is just a case of temporal dispersion. I just wanted to show you in case somebody gave you a sheet and said, what does this show? What is this electrophysiological abnormality? It's temporal dispersion, because you can see the duration has increased. It'll be more than 30, the duration. And it's not really a conduction block, it's temporal dispersion, but it means the same thing. It still means focal demyelination. Now, its clinical implication, it's demyelination. But if this was the only abnormality seen on the study, that means your upper limb sensory and motor studies are normal. The rest of your motor studies in the lower limbs are also normal. And the only abnormality is this on stimulating the tibial nerve and recording from the foot muscles. Would you still diagnose demyelination? Actually, you must not. You must be careful. These are one of the pitfalls of demyelinating neuropathies. The tibial nerve there are two issues with tibial nerve. One is that it records from the extrinsic foot muscles, and in older people, the extrinsic foot muscles may be a little bit sort of worn out and degenerated, and it will always can give you erroneous values. So if you have just an isolated tibial temporal dispersion or what looks like a conduction block without any other nerves being affected, especially if the patient is symptomatic, I would ignore it. If the patient, especially if the patient is asymptomatic, I would completely ignore it. That will not be enough to give you a diagnosis of demyelination. The other problem with tibial studies is that your proximal stimulation is at the popliteal fossa. So you can see the popliteal fossa, there's a lot of fat there. It's very difficult for you to actually reliably stimulate the tibial nerve at the popliteal fossa. So you can have this sort of false conduction block, which is actually technical. So please, just when you see the tibial abnormality with no other abnormalities anywhere else, please don't diagnose that as a demyelinating neuropathy. You need to see another motor nerve ideally, before you can actually say that there is any demyelination here. But otherwise, this picture does look like temporal dispersion. I mean, nearing the end, I think this is probably one of the last cases here. So 25-year-old young lady, some imbalance issues with paresthesia. So paresthesia starts in the hands and then it progresses to the feet. So that's a non-length dependent involvement clinically. And the abnormalities, so these are sensory nerve conduction studies here. As you can see, the amplitudes are all completely reduced. Another interesting thing about the amplitude, so basically this is postganglionic, isn't it? The amplitudes are, snap amplitudes are involved, the snaps are involved, so it's postganglionic. But the characterization is axonal. Characterization is axonal, your conduction velocities are completely normal, there is no evidence of demyelination, latencies are completely normal, no evidence of demyelination. So it's an axonal sensory involvement. Other interesting thing here is that it is non-length dependent. So you have your sural, which is still preserved, but you have a superficial radial, which is reduced, and MABC, that's your medial antebrachial cutaneous nerve, which is reduced. So all your proximal nerves are affected, your upper limbs are affected out of proportion to the lower limbs. So this is a non-length dependent, generalized, sensory, axonal lesion. Okay, and this is what sensory neuronopathy or dorsal root ganglionopathy looks like. So this is very specific, non-length dependent sensory involvement, and this is what a DRG looks like. Severe non-length dependent sensory neuropathy, neuronopathy. And this is important to identify this because there are only very few specific things that cause it, like rheumatological disorders like Sjogren's or paraneoplastic or immune mediated, and they are treatable and they're all treatable. So it's very important to see this and not diagnose this as a diabetic sensory neuropathy or whatever it is. Okay, so it's important to identify this because this actually has specific etiologies which you can actually address. This is another example of a DRG or dorsal root ganglionopathy. So if somebody hands you these sensory nerve conduction studies, this looks a little bit more asymmetrical. As you can see, left median is absent, right median is reduced, amplitude is reduced, but it is present. Left bilateral ulna is absent. The sural is still present, but it's very reduced. Superficial peroneal is absent. So this non-length dependent, where this lower limb sensory responses are still present while the upper limbs are absent, that's where the clue, that's where the coin should fall, and that's where the clue should come that you are not looking at a non-length dependent sensory neuropathy, which could be a dorsal root ganglionopathy, and you need to report this appropriately. So this is our final study, final case, sorry. So this nerve conduction study was undertaken on a 59-year-old lady with radiating left-sided neck pain. So she has symptoms suggestive of radiculopathy. It looks like a cervical radiculopathy. And nerve conduction study was done, and this finding was noted in the nerve conduction study. Describe and name the finding. So what was the finding that we saw here? This is a motor nerve conduction study of the left ulnar nerve recorded from the ADM, abductor discharge minimi, and left median recorded from the abductor pollicis. Ignore this ulnar bit, just left median recorded from the abductor pollicis brevis muscle. So here you can see what looks like a conduction block, isn't it, at the cubital tunnel, without slowing in conduction velocity. And here, if you see the median nerve study, you can see that the distal amplitude is reduced while the proximal amplitude following stimulation at the cubital fossa is actually increased. So for all of you who actually do the studies, you will know that stimulating the median nerve at the popliteal fossa, at the cubital fossa is much more difficult technically than stimulating it distally at the wrist. So usually if you drop the amplitude tends to drop at the cubital fossa. So when you have an abnormality like this, which is almost like a reverse conduction block, if that makes sense, with normal conduction velocity, and these are the pictures. So you have a drop here, which could happen in an ulnar neuropathy at the cubital tunnel. But you have a median that looks like this, where the stimulation at the cubital fossa is much higher than stimulation at the wrist. This is what a Martin-Gruber anastomosis looks like. So MGA, the most common MGAs are of 3 types. There's a 4th type, proximal MGA, which is much less common. So after this, you should go and have a quick look at MGAs. So in case something is given to you like this, somebody hands something like this to you, you need to know that you need to be able to identify that MGA, because that will have repercussions, because somebody might diagnose this as ulnar neuropathy, which is not. What further nerve conduction studies would you do? So you need to, MGA is actually the median, the fibers cross over from the median nerve to the ulnar nerve in the forearm. And what you then do to prove that this is an MGA is you record from the ADM, but you stimulate the median nerve at the cubital fossa. So you get a response, those fibers which then travel through the ulnar nerve later. So then that is the way you identify that, okay, this is an MGA, and then you put that report in your summary of the test and make sure it doesn't come into opinion, because once it comes into opinion, people can get confused, but make sure it is mentioned in the summary. So MGA to ADM, median ADM stimulation at cubital fossa. That's what you need to do. So this is just a quick recap of Martin-Gruber anastomosis. So the crossover fibers, so median, ulnar, and the crossover fibers happen from median to ulnar. So three types more commonly. Most common type is actually crossover fibers that innervate the FDI. And less commonly, you see crossover fibers that innervate the ADM. And then proximal MGA, which is very rare. That's why you must stimulate the ulnar nerve at the level of the cubital tunnel. You must make sure that you stimulate 3 centimeters distally from the cubital tunnel. From the medial epicondyle, you should be 3 centimeters. If it go 2 centimeters or below, then you will catch a proximal MGA if it is there. Proximal MGA just means it crosses over much more proximally. Crossover fibers that innervate the thenar muscles is much rarer. What you will see will be one of these two. Okay. So finally, to recap, you are given your nerve conduction studies. So you first look at it. Is there any abnormality? Is the SNAP affected? Is the CMAP affected? If the SNAP is affected, you go down this sort of pathway. So remember, first is localization. SNAP is affected, postganglionic. As long as it's a nerve that has a SNAP, that has a sensory response, sensory nerve, which you can actually reliably test. Then you look for distribution. So distribution is it focal? Is it multifocal within a single limb, which could make it a plexus, or multifocal in multiple limbs, which could be mononeuritis multiplex, or is it generalized? Within generalized, is it more symmetrical or is it more asymmetrical? Then you characterize. So axonal versus demyelinating, and these are the kind of examples that you could look at. So you localize first, pre versus post-ganglionic, distribution next, characterization, axonal versus demyelinating. This is as simple as it is for nerve conduction studies. And just some examples of a focal axonal will be a peripheral nerve injury. Focal demyelinating will be a peripheral nerve compression like carpal tunnel syndrome, ulnar neuropathy, or a radial nerve with a spiral groove. Multifocal axonal could be a multifocal axonal within a limb, single limb will be plexus. Multifocal axonal within multiple limbs, different areas could be mononeuritis multiplex. Multifocal demyelinating could be the CIDP variants like MAD-SAM, or multiple peripheral nerve compressions also, multiple ulnar neuropathies at the elbow, or bilateral carpal tunnel syndrome. Now, generalized symmetrical could be an axonal peripheral neuropathy, if it's axonal, and if it's a generalized symmetrical neuropathy, if it's demyelinating, it could be inherited demyelinating, or it could be a CIDP. Okay, so these are kind of the examples once you have classified. So see, the classification will help you not only localize, it will immediately help you with the etiology. Okay. Now, these are the bits where your SNAPs are normal and the CMAPs are affected. So it could either, so what we traditionally call as preganglionic. So it could either be true preganglionic, where the lesion is at the root or anterior horn cell, or it could be actually a motor axonopathy, where then you have to characterize whether it's a motor axonal axonopathy. Motor axons are involved, but is it involved in an axonal pattern, or is it involved in a demyelinating pattern, like a motor CIDP, for example? Or it could be a presynaptic neuromuscular junction disorder, or a very severe myositis. So we'll talk about the presynaptic neuromuscular junction disorder in the next talk, and polymyositis in the next talk. So, but these are the 5 areas, the 5 localization points that you will have if your SNAPs are normal and your CMAPs are affected. So remember, SNAPs normal, CMAPs affected doesn't automatically say root or motor neuron. It could also be motor axon. It could also be presynaptic neuromuscular junction. It could also be a severe myopathy. So next time we'll talk about EMG. I'll show you some examples, video examples of abnormal spontaneous activity and things like that. There will be cases, probably there will be fewer cases, because nerve conduction studies, there is so much more to talk about in nerve conduction studies, but we'll talk about neurogenic versus myopathic. We'll quickly go through repetitive nerve stimulation studies. I'll give you examples of single fiber EMG in case somebody gives you a jitter study and asks you to look at it and tell what it is. We'll have a few case discussions. We'll discuss about root radiculopathies, roots, motor neuron, and myopathies. Thank you. Any questions?
Thank you, Dr. Radhika. Excellent, very comprehensive. You covered almost all the important scenarios. You've shown how to interpret various combinations and permutations. I'm sure residents have really benefited from the presentation. I don't see any questions. We'll wait for a few minutes to take up some questions.
The other thing also I wanted to ask everybody is, if you have any questions, any other cases that you want, I have a bunch of cases. I'm happy to. I didn't show them all, but if you have any specific things that you want me to cover, we'll do that in the next time. No problem. So that's fine. And also any cases that you're struggling with, you can email me. I mean, I can give my email to the organizers and we can go through case studies also. No issues.
Forgot to mention that your presentation is recorded and it will be there on the YouTube channel and also a website. In the flyer, I have mentioned that. People who have already left the presentation can also go back and see the presentation later. In 2 days, it will be put up in the YouTube channel. So really helpful.
Thank you. Thanks for giving me the opportunity as well to the organizers.
Wait for 2 minutes.
Sure. No problem. I just hope you don't get scared looking at nerve conduction studies in EMG. I mean, they're so easy. If you think about it, nerves only get affected in 2 ways, axonal or demyelinating. You just have to learn by heart the brachial plexus. Okay, just these kind of the slides that I showed, just learn those. And there's actually 1 or 2 really good reviews in muscle nerve as well. If you're interested, I can share that as well with the organizers. But you must not be afraid. It's the easiest thing in the world, really, nerve conduction studies. And if you have doubts and you're struggling with any particular case or anything, you're free to email me and we can go through the cases. No issues at all.
Just mention the YouTube. Dr. Krishna Mohan is asking. Name of YouTube channel. It is mentioned in the flyer. Neurology drugs treatment algorithm. Name of YouTube channel. You go back to the flyer. It is there.
I think somebody's actually asked a question. Is there any entity of axonal with secondary demyelination? So yes, fast conducting fibers. If the fast conducting fibers get affected pretty early, then you will have increase in latencies, reduction in velocities, and it can look demyelinating as primary demyelinating. This is where if you're stuck, sometimes it's very difficult to make the difference, make the differentiation. I would really suggest the DFNS criteria, the same criteria that I showed you. If you can just print it out and put it up in your lab or keep it on your phone. If you're stuck like that, you can look at it. But you can get stuck. It can look like that. It can. But the secondary demyelination will be because of loss of fast conducting fibers if the primary pathology is axonal. Sometimes in diabetic nerves, you can have you can have a primary demyelination as well as a primary axonal that happens together. And that's the only other thing, really. Diabetic nerves can all look a little bit not very nice with quite a bit of demyelination going on and axonal along with it. Nodopathy, as in, you mean the demyelinating neuropathies?
So in ADP, they mean in
yeah.
GB syndrome, you have pure nodopathy. With single nerve and without repeat studies, is it possible to suspect?
Oh, so GB syndrome, it's always clinical. It's really clinical. GB syndrome is always very clinical. With a single study, it depends on the timing. Now, suppose you have a patient with good going symptoms and you've done your study at 2 weeks, it sort of, you get your full picture at 2 to 3 weeks. At 4 weeks, it doesn't add anything much. Whatever you get, you will get at 2 to 3 weeks. And then if you've done it at that point, that's fine. But you've done your nerve conduction study at 1 week, then it always makes sense to repeat it later. Especially if you don't, if it looks slightly atypical kind of GBS where they're present, you don't want to miss an SIDP, that kind of thing. Yeah. So it depends on the timing, whether you repeat your nerve conduction or not in GBS. It's the timing of your first study. Title or link of the reviews. Yeah. So these are muscle nerve articles. Dr. Sharma, shall I just forward you the articles and that can be distributed then?
Yes, you can do that. Or in your PPTs, you can add a last slide with the references.
Yeah.
I will upload that also.
I'll send that. Yeah, that's a good idea.
Hope to get the recording of session. It is there in the YouTube channel. I just put that there. It is in the flyer. The YouTube channel name is mentioned in the flyer. Neurology drugs treatment algorithms. That is the name of the YouTube channel. It will be there in 2 days. And also the website Neurology Drugs is the name of the website. It will be put up there also. And write the name of the channel here. This is the name of the website. So, I think there are no other questions. I think we'll wind up. And thank you very much again, once again. It was an excellent presentation. Very helpful.
No, my pleasure.
Purpose.
My pleasure. Thank you.
Thank you very much, sir.
Thank you.
Thank you.
Thanks.
Thank you, doctor.